I'm going to speak on English. So this is a case that I call the Houdini case. You're going to see why. Yeah, it's got a long topic and it goes like extirpation of stacked ostial circumflex stent in the struts of previous implanted stent in LAD, and we ended up with 2 extirpated stents. This case is from my previous hospital where I worked recently, but it's an interesting case that I want to present. So it's a case about 72-year-old male patient with history of coronary artery disease, a couple of stents in RCA due to inferior STEMI in 2016. We did ostial stenting of LAD in 2018. To be honest, this was the procedure that was done previous month before we go up to the circumflex artery. So this is a case about a stable angina case. This patient got hypertension, positive family anamnesis of coronary artery disease. He was diabetic, and he came, as I said, with stable angina, 3rd CCS class. From non-invasive methods, you can appreciate that there is a QS forms into the inferior leads, nothing special from the laboratory and from echo. So this is the coronarography. You can see that there's the stents in RCA are patent from 2016. The stent in ostial LAD is okay. There is no significant stenosis in mid and distal part of the circumflex artery. And this is the stenosis into the distal part of the circ, where we plan to do a simple procedure, going with wire, predilatation, tracheal balloon, and to finish the procedure. So we started the procedures with EBU to 3.5, going with, as I said, with workhorse wire. We did the predilatation. The balloon went very smoothly into the distal part of the circ, and this is the result after the predilatation. So we wanted to finish the procedure with depth, but we changed our position and we took a stent, 225 over 24, and the stent could not pass through left main. Why? In that time we didn't know why. We pulled the shaft away, and the nurse said, the stent isn't there, it's only the balloon. Where is the stent? And what's next? So this is the mechanisms of stent loss. Everybody who is doing the interventional cardiology is familiar with that. And how to deal. You should start in this kind of situation with small balloon technique, inflate in front of the stent, pull out the stent, or to crush the stent. So we started with small balloon. We tried to push the stent away from the left main ostium, but without success. What exactly happened, what is the mechanism of this stent loss, is that the stent which is implanted into the ostial part of the LAD, there's a couple of struts there protruding towards the left main. So when we pass with the wire, we pass through that struts. And plan B was to crush the stent, but neither of these plans were a success. So the expanded stent is still there. You can see that it's visible. So we put the guide liner, guide extension system, try to secure the bigger support and to pass with bigger balloon, but this was a failed attempt. So this was our bailout choice with loop snare. We go with the snare. Catch the stent. We thought it was in the guiding, but we pull away the whole system, but the stent, we extracted only the proximal part. Where was the rest of the stent? We looked into the guiding, it wasn't there, and of course it was still there at the same place. So again, the same procedure from the beginning, and you can appreciate, look very carefully how we pull away the stent from the circ, but also took away the stent from the LED. At that time we didn't know that we extract the stent from the LED, so the heart pumped in that time, so we didn't expect this. We invented a new technique, exactly, but a piece of the stent was in front of the sheath. We didn't want to proceed from the radial axis, we go from femoral axis. First of all, we check the aorta, is everything okay? Everything was fine. Then we did the angio. Surprisingly, there was no dissection into the whole left coronary system, but we want to be precise, so we did IVUS first in LED. Watch very carefully. The IVUS showed that there was only a plaque into the ostium. I don't have the pictures from the procedure when we put the stent into LED. There was a severe stenosis, so we don't have explanation of how this severe stenosis, only with 1 month of treatment with stent, went gone. Only plaque. Then we did checkup on circumflex artery. There was no dissection either. So we continue with the procedure. First of all, we put a stent into the circumflex artery. We changed our strategy. Then, beside that, there was no significant stenosis into the ostial part of the LED. We decided to put a stent over there, so we put a stent 3.5 and we post-dilate with 375, and this is our final result. So, we tried to pull away the piece of the stent that was left in front of the introducer. We tried with balloon, we tried with a couple of wires that go and make some kind of improvised snare, but we left a piece of souvenir over there. So, what are the conclusions? That complications happened, and we must learn how to detect and treat them. The experience of the operator is critical in these situations. When there's a situation of stent loss, we should retrieve, do not retrieve, deploy crush, and attempts of retrieval may make things worse. Retrieval approaches require imagination, creativity, flexibility, and excellent visualization. When this kind of situation happened, you must remain calm and communicate with the team. So, 1.5 years later, the patient came again back with chest pain. At that time, we know that the piece of stent left in front of, into the radial artery. He was highly obese. He refused to go with femoral approach. We didn't want to go to left, so we did something unusual, distal lunar approach. And we did the angio. Oops. Може да там да пусти? Neće da krene. Samo sekund. Vidite ovdje, this is the stenosis, instant restenosis into the circumflex artery. So we did here predilatation with non-compliant balloon. After that we put depth, and this was our final result. А може да пробвате да пушите това нече? Да. So you must believe me, it was an excellent result. So this is the arm after the procedure, 100% of saturation, and the patient was discharged 2 days later. So thank you very much for your attention.
Thank you for excellent cases. Dr. Tasic, just comment, why did you change your first decision for the DCB to stent?
I don't know. The procedure started one of our fellows, so he decided to change the strategy. I was called, I was taking my lunch, and when they called me, the stent was already stuck into left main. So I don't know why he changed it.
Okay. No neki pitanje, komentar.
One
sorry,
more
just-
question. Why distal ulnar on the same arm? Why not use the left arm, for example?
Why we don't use the left arm? Because the patient was highly obese, and I didn't want to force my back. That's my decision. That was my decision.
Always you have a good explanation.
Yes.
Well, congratulations on the case. I just want to ask, if you had a loop snare, why you didn't use it first?
Because we think that we will finish the procedure a little bit easier, only with balloon. So we took the snare at last point, because in every time we had a couple of cases where we lost the stent, and we finished the procedure only with balloon. So the first choice, always balloon, always balloon. It was a stent that was not too big. It was 2.25 stent. So we could crush it. We will go into very complex left main procedure, yes, but we decided to go with balloon first because it's always the first choice.
But if you treat your stent wasn't the wire, if you treat the stent with the balloon, then the loop snare you will not be able to easily retreat it from the.
If we
left
use the
main.
balloon first,
Yes.
but if you use the balloon and the balloon passed, we'll finish the procedure with crushing the stent and we'll go into the PCI. We will not use the snare after that. We'll not try to took away the stent, you know. We'll crush the stent and we'll go to the PCI procedure.
And the stent was 2.5.
2.25.
2.25.
Yes.
And you could expand it to. I don't know.
No. The first choice was to pull away the
crush
stent, to go down with the balloon and pull out the stent. We didn't figure out that the stent was tucked into the struts of the LED stent. We took that the stent fall out only to the left main. We figure out in couple of attempts when we try to go with the balloon. You know, first of all, we think that the stent fell out only from the balloon and it was moving into the left main. But then we figure out when the balloon didn't want to pass that it was stuck, and then we take the snare.
Okay, and when you have the previous ostial LED stenting, did you consider imaging before this procedure, because you don't know how much this stent protrude to the left main or is not covering the
Why
left main?
we go to the distal circ? Why to go with IVUS of LED?
But I'm not sure, I don't believe in the ostial stenting of the LED, isolated ostial stenting, because either you miss it, the lesion, either you...
I agree with you. I agree with you. You should go with left main to LED. I agree with you. Absolutely. Absolutely. There is no only ostial LED stenosis. You should go and you should go from the left main towards to LED. Yes. I agree with you. I agree with you. But the first procedure isn't done by me. I'm in the second procedure where I go the snare, put the stents, and the third procedure where the videos didn't want to show with DCB and the distal ulnar.
Okay, thank you.
Thank you. Da. Zato što tako sam rešio. Mnogo dugačko vreme sam se mislio da postavim stent tamo, zato što Ajvo se pokazuje da je samo plak. Da, ali mi nemamo još objašnjenje kako seriozna stenoza, što je bila, tad je bila 90% stenoza, je prosto bila samo plak, nesignifikantna stenoza, samo jedan mesec posle stentiranja LAD.
Ovi komplementarni ovi doktori to nazivaju endaterektomiju.
Tako je.
Može jedno samo pitanje još ovamo. Šta je bila indikacija uopšte da se radi PCI-Lcx? To je malo teritorija iz hemije. Da li je bio simptomatičan? Trebalo testirati. Znači kad se rade neznačajne lezi, mislim male...
Mi radimo u privatnoj bolnici. Mi radimo u privatnoj bolnici.
Razumijem tada.
Imamo još pitanje, Kleč? Ne, hvala doktor Skudov.
Hvala.